Hi, my name is Tracy Tavera. I'm a professor of pharmacy and the director of interprofessional education for the University of Rhode Island, an adjunct professor of medicine for the Warren Alpert School of Medicine at Brown University. I'm also a health services researcher and clinical pharmacist practitioner at the Providence VA Medical Center. And currently with the ADA, I serve as the chair of the Cardiovascular and Diabetes Research Interest Group. So the Diabetes and Cardiovascular Disease Interest Group put together a panel of speakers, and the focus of this and the purpose was to bring together basic science researchers, clinical researchers, and translational research to inform innovative cardiovascular outcomes. The first speaker, the main takeaway was with Dr. Peter Crawford. He is a ketone expert, and he showed that in heart failure, which is highly prevalent in patients with diabetes, that altered ketone metabolism leads to pathophysiologic alterations and detriment to cardiac myocytes. And this also occurs in the liver. He also showed that SGLT2s that we commonly use in diabetes and heart failure and kidney disease, they do improve ketosis, but not to the level or magnitude that would explain their pleiotropic benefits that we see across the board, and that there are other possible mechanisms that are contributing to the benefits that we see in our patients. The DELIVER trial was a randomized controlled trial that evaluated the effects of empagliflozin in patients who had heart failure with an ejection fraction greater than 40%. And what they found in the overall trial was that dapagliflozin reduced cardiovascular mortality and heart failure hospitalizations in patients who received dapagliflozin. Those patients with higher level of BMI had greater symptom improvement. So not only were their outcomes improved, but they felt better across the board. However, what we do know is that there is a gap, and that when we look at utilization of SGLT2 inhibitors across the board in the United States, that only patients, about 10 to 14% of patients on average, are receiving these agents when they are indicated. The third trial that we saw was Deborah Wexler's trial, and she showed us her study, which was a randomized controlled trial of the Real Health Diabetes study. And what we found, not surprisingly, is that intensive lifestyle intervention works for our patients, right? However, the question remains is, can we broad scale, disseminate, and implement this in the real world clinical setting? They did this randomized controlled trial that randomized patients to 3 arms, okay? One arm was in-person group interventions. The second arm was via telephone group interventions, and the third arm is the traditional gold standard of medical nutrition therapy. And what they found at 1 year is that those patients randomized to either group intervention in person or via telephone had a greater reduction in body weight of about 6% after 1 year versus only 2% in MNT. However, at 36 months, they found that the MNT arm was able to catch up. But what I found especially interesting is that they did pre-specified subgroup analyses, right, in 2 distinct populations. The first analysis was in those patients who identified as having food insecurity versus not having food insecurity. And they compared the 2 groups, and they performed similarly. So it shows that this less intensive intervention in targeting 7% weight loss and 175 minutes of physical activity worked well in a diverse population. The second group that they proposed to study to look at was by way of socioeconomic status. And the way they used this as a surrogate were those patients who had less than a high school diploma versus those patients greater than a high school diploma. Okay, and what they found is that those patients who had less than a high school diploma actually performed even better, suggesting that this intervention worked really well for those who had a knowledge or skill gap. So bringing together maybe the clinical trial evaluating dapagliflozin in underutilized populations, perhaps we could use Dr. Wexler's model to expand access for our patients. The implications is that we have a nice model that we can use multidisciplinary providers to implement these interventions and expand them to especially to underserved populations. Of note, in Dr. Wexler's trial, about 14% of the patients identified as Hispanic, and they adapted the intervention for Spanish and English participants. And so it shows that this is not only feasible, but it is efficacious and sustainable. I think it's about implementing this research in even broad scale, right? We now know it is feasible in these community care clinics. And now I think our next step in this research is to think about how we can get this implemented even more broadly and across the nation. Not every community has this highly skilled nutritionist, but maybe using other practitioners such as pharmacists, right? There's plenty of data to support clinical pharmacists or exercise physiologists, as well as behavioral psychologists who implement behavior change.